Good morning, good morning, good morning, everyone. It's early if you're on the West Coast. If you're on the East Coast, you've probably had several cups of these by now. Welcome to VertiMax VIVE. My name is Dan McDonough, and do I have a guest for you today? You know, when I was talking to Ed's mom, the first thing she says to me is like, Eddie, he's got a great face for radio. You know, my mom said the exact same thing to me, but I beg to differ. Ed, you look fantastic for 60. Welcome
I know.
to the
Thank you. Yes, thank you. Yeah, I don't feel a day over 80, so it's great. It's amazing.
Hey, that's absolutely Ed, thank you so much for joining us today. We've got a great topic that I want to talk about specifically today called blood flow restriction. You know, in our industry, which would be performance, health, and fitness. I'm not quite sure where I heard the line before, but there's something when it comes to education. If you're the smartest person in the room, you're in the wrong room. Whenever I'm in the same room with you, I am certainly not the smartest, my friend. I can't tell you how much I've learned from you over the years, and I'm very excited to be sharing your knowledge with our audience today. So from Dallas, Texas, Dr. Ed Le Cara, thank you for joining us today.
Thank you so much. Yeah, I'm honored to be here, and yeah, it's always great to catch up with you.
Yes. So I want to talk a little bit about my personal experience with Ed. I probably met him kind of 2012, 2013, back when I was at TRX, and Ed came in to kind of be a major driver of our TRX sports medicine course, which I think is probably one of the best courses that they got. And that's when I truly got exposed to Ed and his knowledge. And what's great about Ed that I've learned over the years is that he always asks great questions. For as knowledgeable as he is, he's always seeking to understand. And then I got injured. I was probably about 1-2 weeks away from heading over to Europe to do this awesome bike trip that I do every year. And I pulled my calf, and I'm like, I gotta call Ed. And so Ed, over the phone, just kind of talked with me, asked me what was going on, asking great questions. And then in combination with some blood flow restriction and some other modalities, I was able to get on my bike and go do my trip in Europe. And that's when I first really got exposed to blood flow restriction from a recovery and injury perspective. But I know it kind of it's really starting to find its way into the sports and performance world. So I'd love for you to tell our audience kind of just how you got exposed to blood flow restriction, where it originated, and kind of where it kind of sits today in our industry.
Yeah, sure. I've been in practice for 21 years. My undergrad degree was exercise physiology. My first certification really was from the National Strength and Conditioning Association. So I was, even as an undergrad, I had this just huge lust and yearning to learn more about our physiology and our adaptation, and my own training, because I was a Division I wrestler. And what we learned in undergrad exercise physiology is that when we exercise, we have to break down tissue. And from that breakdown of tissue, you have adequate rest. And from that adequate rest, your body recovers and becomes stronger and fitter and have more aerobic capacity and all these things. So that was kind of this underlying, understanding of adaptation. Mm-hmm. One day I'm sitting in my clinic, and I think I gave a patient, like she had a hamstring issue, and I gave her glute bridges with no weight, and I called it, we're going to do some strengthening exercises. And as the words are coming out of my mouth, I was like, these are not strengthening exercises. There's not enough load. Like, maybe we're getting some, type 1 activation, maybe some type 2 if we get tired. But it really had me like thinking, and I kind of was feeling like I was in this quandrum. So I stopped calling any light load resistance training strength training, because it really wasn't. And, kind of being in the rehab world, we only have so many visits with a patient, right? I have 6 visits, I have 8 visits, I have 12 visits. Well, you and I both know physiological adaptation takes somewhere between 12 and 16 weeks of 3 times a week training in order to get a true physiological adaptation. It's not easy to go in the gym and go get bigger biceps or, get stronger. Now, some of that is neurological, of course. But especially in the early phases. But so I got in this mental fog of like, what am I really doing in the clinic? Like, what is really happening here? And when I was doing my PhD work, Kyle Kiesel from the functional movement systems or selective functional movement, or the FMS, as a lot of people would know it, he was one of my professors, and he introduced me to kind of this movement-based evaluation. And it made a lot of sense to me because in the clinic, I might have 4 to 6 visits with somebody. I can help them move better with manual therapy. And I wasn't really causing true physiological adaptation from strength and hypertrophy or muscle size growth. So I kind of go a deep dive into movement. Like, you can't touch your toes, I'm gonna make you touch your toes, or at least get you so you can touch your toes. If you can't, you don't have good external rotation of your shoulder, I'm gonna give you exercises and do manual therapy to do that. Because it made sense to me that in this short period of time that I had with a patient, before I release them back to their CrossFit or their personal trainer or back to their normal fitness, I try to improve their function the best that I can with the time limitations, money limitations, all those limitations. So for about 6 years or so, I was like the movement guy. I'd go to like these conferences, and I'd bring people on stage, people couldn't touch their toes. And then I'd do a couple things that I had learned through Kyle and some other people, and they're touching their toes, and everybody thought it was cool. And I thought I was cool, and all these things.
You are cool, Ed. Let's just
No, I'm not cool. I'm the biggest nerd there is. So then my friend Skylar Richards, who was he was at FC Dallas here in Dallas, Fort Worth area. He was with the MLS team, and he had the lowest injury rate as far as lost player time in the MLS. And that's a big deal because MLS season is long, it's arduous. They play a lot, they play often. So if a dude is running sports medicine for a place that has the lowest injury rate, I'm listening to that guy, right? So he said, you got to check out this thing called blood flow restriction training. And I, like most people, was like, this doesn't sound right. So as what most nerds do, I go on PubMed and I go on a couple of my search engines and I start looking up what's the literature supporting blood flow restriction training. And to my surprise, 600, 700, 800 studies came up validating its safety, its efficacy for strength, for aerobic capacity training, for rehab, for performance, all these areas. So I'm like, huh. And the coolest thing about it is I get the adaptation effect of high intensity training, which I said before would take somewhere between 12 and 16 weeks.
Yeah.
And I get that adaptation effect in about 3 to 4 weeks, strength and hypertrophy, while only using light loads. Because remember, I'm working with people that have injured tissue. You come to me when you have a torn rotator cuff, you have a torn hamstring. You're not lifting heavy loads at that time. I need to be able to light load you. And that's where light loads come into rehab. TheraBands, light dumbbells, body weight exercise, because that's all that injured tissue can tolerate.
Yeah.
So as I continue to develop and learn, being able to do the exact same exercise I was doing, but applying a cuff to either the upper extremity or the lower extremity, reducing blood flow into the system tricks the brain and body into thinking you're doing high intensity exercise, and you adapt in a much faster time period. So it's perfect for rehab because people can't lift those heavy loads. And I typically only have a short period of time with them, 3, 4, 5, 6 weeks to get them the best that I can before they kind of move on to their next person. So that was all about 2015, 2016. And since then I've just been like, deep dive, BFR, not only in my clinic, you can see my rehab stuff behind me, but also going out and trying to teach. And I just wrote a book and, trying to educate both the rehab world and also the strength and conditioning world, fitness world on the benefits of BFR.
What's really interesting is, in terms of, you've kind of got exposed to it in kind of this kind of rehab area, but a lot of research that I've read as of late, it's being adapted quite heavily into sports performance, right? And you can correct me if I'm wrong in this assumption, but I think there's still a lot of athletes out there that still think that more is better, right? So from a psychological perspective, right? You got the mind of an athlete that thinks, I can think back to my experience that, if this guy's resting, I should be training, because if I'm training, I'm getting better, right? So from a psychological perspective, I find it really interesting that incorporating BFR into their kind of strength and resistance training, psychologically making them think they're doing hard work because they're getting that pump, they're getting that burn. But then in terms of high impact and protecting the joints, and it seems like it could be a really, really interesting intervention from a sports performance perspective when you're dealing with athletes who really want to go hard all the time, right? Because you're getting release of growth hormone. It's been shown great for muscular hypertrophy. So if you're coming back from an injury and you're looking for muscle imbalances and getting them as close together as you can, I'm finding it fascinating.
Yeah, and what's really really cool about it is that most of our athletes, even like, just think about during the season. I remember being a young guy, like maybe, high school probably, and watching Michael Jordan at the time was the guy, right? I mean, like, he's the guy, he's still the guy, but, and the ESPN did this special kind of interview with him about his fitness during the season. So Michael Jordan would play his whatever minutes, 34, I think he averaged over his career, 32, something like that. I could be corrected. After each of those games, he would go and lift weights. Now, that seems like that's a normal thing nowadays. But 30 years ago, that was not normal, right? They would go smoke cigarettes, go, have a high fatty meal in most cases. And he was training. And when ESPN asked him, why do you train this way after you've just played and are exhausted from this game? And he said, over the course of the season, because I play so much and I can't lift as much, if I don't lift weights, I will lose 15 pounds or so over the course of the season. By the time I get to the playoffs, which we always make, right? They always make the playoffs. My durability is way downhill. And so you think about these athletes that play all season long, then they have to go another full season. If you're in the NHL, you're in the MLS, you're in the NBA, and they have to play this extra season of the postseason. They're trying to maintain muscle mass and strength. If you don't have to use heavy loads to do that, and you don't have any damage, because when we do BFR and we don't do it to failure, there is little to zero muscle damage that actually occurs. So my recovery is essentially, once that peripheral fatigue is gone, which is usually within like 6 or 8 minutes, I am pretty good to go. And I don't, like, we have studies that are showing people training twice a day with BFR with no adverse effect. So I can now use that in my season. I have a game tomorrow, I can still lift today. I have a game in 2 days, I can still lift today, without what we know what happens with delayed onset muscular soreness, which is decrease in torque in the muscle, decreased ability for contraction, decreased strength. So it just makes sense that during the season, twice a week, which has been shown to be as effective as 5 times a week with BFR, even if you only lose 1% of your muscle mass over the course of the season, is way better than 10, 15, 20%. And then what we're trying to do now is look at studies of mixing blood flow restriction with high intensity exercise. That's what I just presented on at National Strength and Conditioning Association last weekend in Orlando. We did a study with Division I football players. And what we did is we just mixed BFR with their normal high intensity training. And people will say, well, why would you do that if they're young and athletic and healthy? Well, when I was in the athletic training room at St. Mary's College of California, not too long ago, before I moved to Dallas, we had a lot of injuries that occurred in the weight room. And it didn't make any sense to me. I'd be like, why are we getting hurt in there? They're not a weightlifter. They are a basketball player. They are a soccer player. Let's not hurt our back lifting heavy loads if we can get away with it. Let's have perfect form, use lighter loads, but get the adaptation that we need. And BFR helps that, because you don't have to lift the heavy loads. You're not causing muscular damage. You can concentrate on your sport. Now it's different if you are a weightlifter, if you are a power lifter, if you are, you do have to lift those heavy loads. But I have many power lifters that I work with that supplement BFR after their normal training to get those little small areas that are not quite where they want to be. Or like my fitness people that go on stage, they, maybe their calf isn't right where they want that symmetry that they want. They want a little hypertrophy, especially when they're starting to cut weight the last 6 weeks towards a show. They can use BFR, light loads, they're still either maintaining or building while they're starting to cut their caloric intake, which, as we all know, is very difficult to do, and then use it as a pre-pump prior to the stage. So there's so many cool applications. If you want to be stronger, if you want to have larger muscle, why not?
Why not?
Why not?
Now, let's talk some reality here. I remember when you first introduced me to blood flow restriction, and as you know, I'm a cyclist. Mm-hmm. And so you're like, Dano, give this a try. And this was when I'd injured my calf. So I was trying to get myself back to at least be able to enjoy my bike trip with the thousands of dollars that I'd spent to go over to Europe. And you said, well, put the blood flow restriction cuffs on here. I'll send you a pair, and get on the watt bike and just start turning.
That was nice, okay?
Right. And you warned me that it was not going to be comfortable. And I'm used to uncomfortable as an endurance athlete.
Sure.
But let me tell you, that was some of the most uncomfortable minutes I had ever spent on a bike. So let's talk about that feeling of being uncomfortable and how we can integrate that with our athletes and even the general population. So we know blood flow restriction has amazing benefits. We've just discussed that, and even increasing VO2 max. So in terms of getting adaptation, in terms of acceptance into our industry, what do you think is the best way and the best approach to kind of integrate this as a modality into our field, knowing that it's not going to be comfortable?
Yeah, sure. Well, I think that I use the term undercook versus overcook people a lot. Mm-hmm. I can always throw my filet mignon back on the barbecue. Yep. But if I've burnt it and it's already well done and you like it medium, you're no longer coming to my house for barbecue, right? So I say the same thing with athletes, or my patients, when, if undercook it for about 2 weeks. What the literature suggests, there's a major researcher, Jeremy Loenneke, out of University of Mississippi, Ole Miss, and he's published a study looking at how long does it take to kind of adapt to blood flow restriction? Like how many sessions does it take? And so we do what's called, or I train people in doing about a 2-week on-ramp, which is we use a little bit lighter pressure, we use a little bit less weight, we do isolated exercise versus compound exercise. So isolated meaning single joint, like a bicep curl, compared to doing like a compound exercise like a lat pull down where I'm using multiple joints. So we want to utilize a lower training volume, even with the BFR, just to get people used to it, because it takes about 3 sessions for people to be like, okay, I understand what this is supposed to feel like. And now I'm starting to understand like how this all works. Like, and so I think lighter pressures to start, less volume, meaning maybe max 3 exercises per area, and using the lighter loads. I also recommend kind of knowing, for people that are not injured, it's if you know what your 3 rep max is for, let's say, a back squat, you can convert that to your 1 rep max. We're working at about 20% of that. So it's very light load. So you use that light load, but knowing kind of where you are and where you're starting, and then just undercooking it a little bit as you get into it is my recommendation.
So obviously having a practitioner or a strength and conditioning coach that's very, very familiar with blood flow restriction and the protocols certainly is very important, because you don't want someone just to grab a set of these and have too much blood flow occlusion. So what are the risks if someone doesn't have proper guidance with blood flow restriction? Yeah.
So there's, like any exercise, right? Before you start any exercise, it says, consult your physician if you have any of these, we have the same kind of restrictions. Blood flow restriction has been shown to be very, very safe in the literature. If you have pre-existing clotting issues, we have to be careful. There's a list of things that you should be aware of. But in all reality, that's very hypothetical. There's only been a couple cases where there's been injury during exercise, and those were rhabdomyolysis, when people they overdo it. They don't, they overdo it, but overdo it. I've seen many covering many CrossFit games and CrossFit events getting rhabdomyolysis. It's not isolated to BFR.
Yeah.
many of those predictors of injury are really hypothetical. We just don't really see it. And the reason is if I use too much pressure in the cuff, you can't do the exercise. It's just, it's impossible. So we have a percentage that we recommend, which is 40 to 50% of what's called your limb occlusion pressure. So if I use a cuff as an example, so here's a cuff that I would use on myself for my upper extremity. So we only place the cuffs in two areas, very high up on the arm and very high up on the leg. And we never do all four limbs at the same time, because what will happen is your cardiac output will be reduced because stroke volume is reduced, and then your heart rate goes through the roof, and you can't, it's not recommended. So we put the cuff on high up here. Now what's happening is when this cuff is not inflated, let's say I'm doing a bicep curl, I have 100% arterial flow into the limb, and I have 100% venous return back to the heart. Now I inflate this cuff to a point where I no longer have arterial flow and I no longer have venous flow. That is the least amount of pressure to make that happen. Zero flow in, zero flow out is called your arterial occlusion pressure or limb occlusion pressure. That would be where we typically do surgery, right? You do surgery in the limb at 100% limb occlusion pressure. Now it's slightly different because before they tighten the tourniquet in surgery, what they do is they flush all the fluid out of the limb first. There's some other things that happen, but that's 100% limb occlusion pressure. We only work at a percentage of AOP or LOP. In the upper extremity, 40 to 50%. In the lower extremity, 60 to 80%. So when I'm saying using lighter pressures to start your training, I would start somebody at like 40% limb occlusion pressure, and then they would do their 2 to 3 exercises for that body part, probably in an isolated, like bicep curl, tricep extension, dumbbell press, and then gradually increase pressure or load, but not both in the same session. So that's kind of how it all plays a part. And imagine when I've got the cuff on, at the percentages that I'm recommending, there's no venous return coming back. So all that is blocked. When that's blocked here, we get what's called a metabolic accumulation. So you're getting these metabolites like lactate, phosphate, hydrogen ion that are byproducts of muscular contraction and exercise. Those are building up down here. So that acidic burn that we get during exercise, that exercise acidosis is accumulating, and there's no way for my body to buffer it really because it's getting blocked. And that's one of the reasons that we think that the adaptation is early on, because this is acidity that's occurring down here pre-fatigues type 1 fibers. Type 1 fibers then have to rely on type 2 fibers in order to continue the contraction of the muscle. The type 2 fibers are more likely to gain size and strength. And then there's a bunch of other physiological adaptations that occur both locally, occurs at the brain, and also occurs proximal. So even though I've only got the cuff here, I still get benefits here. I still get benefits on the opposite side, and I still get benefits at my brain, like what you mentioned, growth hormone. The way that I kind of think of these things is when my body thinks that I'm going to damage tissue, it's going to respond because it thinks I need to run away from Tyrannosaurus Rex tomorrow. Like it needs to adapt and respond and recover as fast as it can. So it anticipates damage to occur. But like I mentioned before, when we do BFR with light loads, you don't cause any muscle damage. Well, some of those responses are stem cell production, which is a kind of a hot topic right now in rehab. You get growth hormone production, insulin growth factor conversion. You get a lot of benefits systemically, the whole system, because you're occluding here. And it's mostly, I think, the easiest way for me to explain it is that the body thinks you're causing damage, which you're not. So that's another reason why we think you get this accelerated hypertrophy and strength in a third of the time, because your body's like, I've got to adapt, I've got to adapt, I've got to adapt, I've got to be able to do this. And because really, otherwise, our bodies would be lazy.
Very good point. Very
Yeah.
good point. Now, in terms of even, I started playing around with blood flow restriction probably about 3 years ago. And I've noticed even since then, it's become more mainstream. It's becoming more accessible. It's becoming more affordable. Now, in terms of, say, finding proper blood flow occlusion level in terms of percentages, so I know these are readily available on the market. So how would an individual be able to determine what their percentage of blood flow restriction is? Is it across the board, whether I'm, a stay-at-home mom or a weekend warrior or Michael Jordan? Is blood flow occlusion percentages the same across the board, or how does it relate to individuality?
Yeah, it's a great question. So there's a couple of factors. The size of the tourniquet makes a difference, like the width. Okay. The largest factor is the size of your limb. So everybody's going to be a little different. So, in order to get to the arterial or the artery, you have to go through tissue. And so the more tissue you have, the more pressure you're going to need. So the lower extremity is going to be higher pressures than the upper extremity. If you have a wider cuff, you're going to need less pressure than if you have a more narrow cuff, because the surface area coverage is occurring. So there's a balance between needing more pressure, less pressure, and being comfortable and really practical. I mean, there's always this kind of like balance that we're working with. Currently, the literature suggests that cuffs should be at least 5 centimeters wide. Okay, so at least 5 centimeters in width. And that's for safety, because the more narrow it is, the more compression you need, and it's going to get really tight, and it can cause damage to underlying tissue like nerve and soft tissue, artery and vein. So you want this width. Now, like, we made mistakes as we were developing these cuffs. The first generation, they were much wider because we wanted them to be safe. And so, but they weren't practical, because as people were contracting, their bicep was getting hit underneath the cuff. So even though these are still at least 5 centimeters, they're still considered wide according to the literature, but they are more narrow than what they were prior. So I think you need to use a reputable company that is looking to educate, make sure that it's safe. And the way that you find your limb occlusion pressure, there's really 2 ways. I either can do it manually, so I would put my cuff on, I would inflate it with a hand pump, and then utilizing an external Doppler, I can evaluate when my arterial flow is gone just by taking a pulse, right? Just using the arterial Doppler to know when that pulse is gone. That's the least amount of pressure is going to be your AOP. Our current version has an automatic Doppler built in and pump. So it's just,
automatic is fairly new too.
Yeah, this just came out in April.
Yep.
So you basically set this, and we have 2 versions of this. One is directly for the consumer. So lots of safety built into it. You can't overinflate it. You can't go to 100% limb occlusion pressure. It will automatically time out if you have it on too long. Like, there's a lot of safety involved, because we both know, being in fitness, that of course people think more is better. And then we have a pro version, and that's designed for people that are working with other clients, like your physical therapist, your chiropractor, your athletic trainer, your strength and conditioning specialist. And there's some other like bells and whistles that you can use. But both of them will find those pressures automatically, and then you can just go back to that pressure each time. And we only keep the cuffs inflated for about 6 minutes when we're doing resistance training, which is just one set of exercises. Well, it's really 4 sets, but it's one group of exercises. Like, let's say I do bicep curl. I do about 75 repetitions, and then I deflate the cuff. So it's right around 6 minutes and 40 seconds if you kind of do it slow and controlled. You wait a minute, and then you reinflate to go to your next exercise. So you're not keeping the cuffs on for, these long durations. You can typically tell when a cuff is not doing true occlusion, especially of the venous system, when people can keep the cuffs on for long periods of time, because you can't. It becomes, like you mentioned before, pretty uncomfortable. And if you have the right weight, like it's enough resistance, by the time you're done with that last set, you're like, please get this cuff off of me. And if that's what's happening and you didn't go to failure, it's about right. That's about what you need in order to get the adaptation that people are looking for.
Great. Ed, Joseph asked a great question, so I'm going to read it to you.
Okay.
Good morning. I'm always thinking of how muscle imbalance and how that can contribute to injury and strains, tears, and more. I wanted to ask if you have the blood flow restriction strap on one arm, and as Ed said, you'll still get benefit results from the beneficial results above the strap and even in the other arm. Is it the same benefit in terms of balance with both arms, or would you have to put the strap on the other arm to get the best balanced benefit possible?
Yeah, that's a great question. Because nothing is always nothing, I don't like to say never because it's usually not true. I usually 98% of the time use cuffs on both extremimies. Mm-hmm. Even if I'm rehabbing one side, I want to get a systemic effect. I want balance. I want crossover. I want that effect of the brain. So I'm gonna use cuffs on both sides or on both sides of the legs. Now the only exception to that typically is if I have somebody that has like a shoulder surgery and it's early on and I can't put a cuff on the surgical shoulder, I'll put the cuff on the opposite shoulder to start and get a crossover effect.
Gotcha.
But the biggest benefit is distal or away from the cuff because that's where your metabolite accumulation is occurring. The second largest benefit is proximal to the cuff. So think shoulder in the upper extremity or think glute in the lower extremity. So shoulder in the upper extremity, glute in the lower extremity. And then crossover is the third best effect. So distal is best, immediately proximal is next best, and then crossover is third best. In the clinic, I tell patients some is better than none, so we might as well do this. And what I tend to do is even if somebody's like really injured, like I have a patient coming in right now that dislocated his shoulder last week. He's got tons of swelling. I will put the cuffs on his lower limbs and have him just go for a walk. I want to maintain his cardiovascular capacity, right? Because we start to lose strength and aerobic capacity by day 7 of inactivity in trained individuals. So people that have worked so hard to become trained, I do not want to see a reduction. So, okay, you can't use that limb right now. We're doing effleurage massage. We're doing other types of modalities, try to push this fluid out of there. But we don't have to lose everything else. And that's one of the things I think that athletes like working with me because I'm thinking whole system, not just, I've got a shingle that's missing on the roof and I need to fix that shingle. Well, you probably have other issues going on and that's why that shingle is. So let's figure out what's causing that leak really versus just a bad shingle.
Interesting. Wow. See, this is why I love to be in the same room with Ed, even though this room is virtual. It is. So Ed, like everything in our industry, right? I'm always a big proponent of learning before you teach, not teach before you learn. So there's a lot going on, obviously, with blood flow restriction, different protocols, all that type of stuff that you've talked about today. So for someone who's interested in learning more about blood flow restriction, where do you recommend they start? Sure.
When I first discovered BFR, 2015, there was really one player in the marketplace, and it was very limited to who he would train. He would only train physical therapists or physicians. And so I didn't really jive with that too well. And it was really expensive. Like a single cuff was $6,000, plus you had to take the training in order to buy the cuff.
Wow.
So what I set out to do was learn as much as I could and really kind of start experimenting on my own, and then experimenting. I don't want to say experimentation. It was, it was based on the research, but experimenting with patients and clients. And so what I did was just recently, or will be published in July. I have it's a book. It's free. You just pay for shipping, really, and it's kind of written not for the clinician. It doesn't have a lot of jargon in it. I tried to make it kind of simple to understand. but it's really for the consumer to just kind of get an idea. And then my goal is to then continue to write more about different segments. Like my next book is going to be on ACL rehab. After that, I want to do one for the aging population, because there's a lot of benefits for the aging population in stem cell production, in growth hormone production, microcirculation that we start to lose. It looks like we can improve the ability for people that are older to utilize the protein that they intake. And remember, as we get older, we have less ability to actually digest and utilize the protein that we're taking in. So we start, sarcopenia, the loss of muscle mass over time as we age continues, and this muscle wasting. And so we're trying to produce, do things to help people, because the elderly are perfect for this, because number one, they can't lift heavy loads. Typically, they're scared to. Number two, they need help both at the cellular level, systemic level, and we just want to keep them functional. So they don't care about lifting heavy loads. They don't care about getting big biceps. They just want to be able to lift their grandkids. They want to be able to sit on the toilet and get off the toilet with a squat. And so that'll be probably the next one after I'm finished with the ACL book. So BFR University is my website that I post. I have a newsletter that comes out every 2 weeks with kind of like new research and podcasts, and so you can get on my newsletter list there. I also do every week on Tuesdays at 1 p.m. Central. I do a webinar, and you only have to register once. You can do that on BFR University. Register for the webinar, and then you get replays if you can't make it. It's 1 o'clock Central, and I just answer questions about BFR. So I just get on just like this, and just start chatting. People ask me questions. I do personal consultations with people if they need help implementing. I've got an app that I can put exercises in, and people can utilize that. I'm happy to help. There's other resources out there for sure, but I'm probably a little biased.
Yeah, no, and this is kind of what my goal and intention in bringing you on was, just kind of get a high level overview of some of the benefits of blood flow restriction. We got one more question here that I think is worth asking, coming in from Joseph again. This is wonderful. Please correct me if I'm wrong. While listening to you guys explain this wonderful technology, it reminds me a bit of PRP treatment without the needles. Obviously, this seems so much more beneficial, consistent in muscle recovery, and being able to do this while working out and being functional is fantastic.
Mm-hmm. Yeah, so anytime that our body can repair ourselves, it's always better than putting cortisone or other things which are really band-aids. And of course, if we can avoid surgery, I usually recommend trying to avoid surgery unless absolutely necessary. So PRP is wonderful technology. The way that I explain it to my patients is that I've got tissue. In this case, it's a piece of paper. And if I do exercise, typically I cause little tiny tears in the muscle. You break down the muscle. Lots of factors associated with this. Blood flow comes in. The byproduct of those tears gets pulled out from the blood flow. Dormant stem cells that sit on top of the muscle cell go into that, and it patches it. Almost like when we were in college, we would put up posters with thumbtacks, and then I didn't want to actually paint and caulk it and do all that stuff. So I used like toothpaste. And you just fill in that little hole. No big deal. Nobody knows the difference. Mm-hmm. When we get a little bit larger of a tear, like let's say I get a muscular tear doing exercise, so now I've got this bigger tear, and it's too big. Like no matter what I do in the clinic, a lot of times these tears won't heal, and so we need a little bit of help to fix that. PRP is now the bridge between this and surgery, right? And then when you totally tear the muscle, it's just like, it's gone, and that needs surgical. So the PRP is super helpful. There's always this grade of how big is that tear. That's why I use diagnostic ultrasound in my clinic to see, how big is that tear? Is this going to be something that responds to the stuff that I do, like shockwave therapy and BFR? but yeah, I mean, you are basically creating your own healing entity using BFR, just like you are with PRP. And if people aren't familiar with platelet-rich plasma, we draw your blood, we spin it in a centrifuge, and we separate that platelet-rich plasma from the red blood cells, and then we inject those the healing factors that are in the blood, that what helps us repair, directly into the tissue. So it is a way to hack the system for sure. Especially growth hormone production is spiked 7x compared to baseline when using BFR. And growth hormone, in the presence of vitamin C, really helps to create collagen. It really helps to create repair. A lot of people think that growth hormone is an anabolic steroid, but it's really not. It's a recovery and repair. So we can increase that. So yes, Joseph is right. It is a way to recover. And I see patients that have a lot of pain. We know something about exercise, which is, I just love being an exercise physiologist, because it's so cool how our body adapts when we apply just the right stress. Too much, we get injured. Too little, we don't do anything. You apply the right stress. And that's really where, your and my expertise comes into, like, how do we help people just get enough stress without overstressing? Is that our bodies are amazing structures and entities, and God made us right, and it will help. It will repair if it can. Now, if we do too much damage, of course, sometimes we need some assistance. But there's almost no substitution to exercise, because exercise reduces pain, whether it's BFR or not. Just getting people moving helps, and it helps not just physically; it helps psychologically. It helps in so many different ways. It's the best antidepressant. I mean, it's like, there's so many benefits, right? So yeah, we just got to get our patients and our clients moving and moving more, and maintaining muscle mass. And BFR is just one of the ways that we can do that safely and effectively, and really efficiently, because people they want things fast. They want things now. And so if you get an adaptation at 2 to 3 weeks, whereas normally it would take 12 to 16 weeks, I'm going to have much better compliance with that, right? It's like getting those first 4 or 5 pounds off somebody on a weight loss program. If they're only losing 1 pound a week, it's really frustrating. You get 3 or 4 or 5 pounds off in the first 14 days. It's like, whoa, like, okay, I can do this.
Yeah. And how's that for retention for your business? Like, let's be real, right? So in our world, right intervention, right dose, right time, right? That's what it's about, right? We have access to all of these tools, and how we implement that, I think, is key. Ed, we could sit here and probably talk for another hour on this topic.
Sure.
And my whole goal was to bring you on because it's still something that's fairly new in our industry. It's popping up at conferences. You're reading more about it in literature. And I just wanted to bring this to the best way I could to this audience, and just kind of answer some of those questions, but more importantly, encourage people to do more research and where they can find more information about it. Not only between your book and the certifications that you run, please feel free to reach out to Ed. I know that we've been dropping his website and where you can find his book and his Instagram handle here as we've been going along. But hand on heart, Ed, I can't thank you enough for what you've done for me and my career, and helping me think beyond here and be here. I think as I get older in my career, I'm just more curious. I'm asking more questions, because there is more than one way to get a desired result. And I think our job, beyond just being, clinical practitioners and strength and conditioning coaches, is just, what do I need to do to have an intervention in order to get our clients, our athletes, to where they need to be, and ultimately, increase their capacity, increase their availability for the long haul. And I love your strategy around that. So let's see. There are a lot of different companies offering BFR. What are the differences?
Yeah, I mean, usually it's going to be the cuff. That's the big difference. How the cuff is manufactured. Is it a manual pump versus an automatic pump? Anytime something gets popular in fitness and health, what happens? A bunch of people drop in. Just go look and see how many handheld massage guns are on the market right now, right? And you say, okay, well, what's the difference? You want to go with a reputable company that is FDA listed, that somebody is overseeing, because we are creating a tourniquet effect. And so you want to use a medical grade tourniquet that's FDA listed, no tourniquets for exercise or FDA approved. So just throwing that out there. But you want ones that are following the research, that know the safety and efficacy, and you want a cuff that is actually doing BFR. If the cuff is not occluding venous return, it's not doing BFR. If you see people doing like plyometrics and a bunch of jumps and like can keep the cuff on for 20 and 30 minutes while they do numerous exercises, that's probably not true BFR, and you're not going to get the adaptation effect. You'll get some veins popping and some stuff, yeah, but you're not going to get that systemic effect that we're really looking for. So look for a reputable company, somebody that's been around for a little while, that has multiple generations, because we're through 3 generations now. This is our 3rd generation. Because we keep trying to adapt, and how do we get better? How do we follow the science? Science changes. How do we make it safer? How do we make it better? How do we make a better value? Like constantly adopting and trying to get better. Education is the key, Ed, right? Regardless of what modality we're using, right? Learn before you teach, not teach before you learn, right? So absolutely. I think any piece of equipment or modality that's got good education behind it, I think that's a great place to start. We saw that with the suspension trainer. Randy invented the suspension trainer. Next thing you know, there's 10 of them, but a lot of those did not have education to back up, right? Education is going to drive not only sales, but it's going to drive the adoption of that modality, because you can be really, really smart up here, right? It's not what you know, it's what you can coach that matters. So thank you so much, Ed, for your time. As I said, whatever you're doing, you look amazing for 60. That smile is absolutely wonderful. Well, the cool thing about my clinic, Botox, a little bit of, hydrofacial, a little pixel, I'm on these screens a lot. And, when you're staring at yourself and you got these, you want to make sure that you're doing all the right things for your skin. Beautiful. All right. Well, Ed, I know you've got to get back to work. Thank you so much for your time. Thank you so much for coming on here and sharing your knowledge and expertise around blood flow restriction. I'm highly encouraging, if you're interested about this, reach out to Ed. He can direct you in wherever you need to be to understand how you need to use it for what you need to use it for. So Ed, thank you so much for your time. Again, Dr. Ed Le Cara, thank you for your friendship. Thank you for your knowledge. And thank you for being a leader in our industry. And thank you very much to every single one of you, both East Coast and West Coast, US and Canada and beyond, wherever you may be. Thank you for tuning into VertiMax VIVE. Thank you to VertiMax for creating this amazing platform for industry leaders to come together and share knowledge, to learn and to grow. Ed, have a great day. And to each and every one of you, thank you so much for tuning in, and we'll see you next time. Bye.